I think one of the good advantages of the virtual meeting is that we're not crunched for time. I personally am not looking forward to having to literally run from one hall to another hall that's half a mile away and then trying to do an advisory board, right after that. And so I think the good thing is that there will be plenty of time for people to review these abstracts in detail. There's going to be a lot of post-ASH summaries, I know, because I'm participating in many of them, I think even more than previous years, that will try to give people very concise, comprehensive information coming forward. Now, I don't want to leave anybody out, so I'm just going to try to, off the top of my head, give a few things that I find interesting, and we'll be looking at the details of the presentation. There will be, of course, updates on Venetoclax. There isn't per se too much new trial data from the VIALE-A. This is the phase 3 study, but there are subsets looking at outcomes in FLT3 mutated AML. This will be presented by Dr. Marina Konopleva as a poster. I think that's an interesting one, actually showing that in the people who have a higher FLT3 allelic burden, especially those who are NPM1 wild type, aza-ven is not performing that much better than placebo, again, suggesting that these are FLT3-driven disease, and going back to something that we have felt for a long time at MD Anderson and others also, that for those patients, FLT3 inhibitor may be better than aza-ven or a triplet approach. But I think this is a good abstract putting together all the FLT3 patients across the last 4 years of aza-ven and showing the outcomes depending on allelic ratio NPM1. Another important study looking at Venetoclax, but not with the HMA or low-dose RSC that we've all kept on talking about last 4 years, but looking at backbone of chemotherapy, FLAG-IDA-VEN. This was kind of abstract that, was not as well analyzed, I think, in the last couple of years, but now the data is coming out more and more powerfully, and I think is going to get more and more attention. We are seeing in relapsed refractory AML, high response rate, CR/CR rate of greater than 70%. This is something we have never seen in relapsed refractory AML, and I'm talking about true CR/CRi, so not marrow CR or MLFS. And in the first salvage patients, especially, the median overall survival is going beyond 14 months. This is quite excellent, and we think the chemo FLAG-IDA-VEN may have a role both in frontline with induction for the fitter patients and maybe in relapse. Another important Venetoclax one abstract will be a study looking at TP53 AML with our MD Anderson combination of decitabine 10-day Venetoclax presented by Dr. Kim, one of our fellows. And here we're actually seeing that the TP53 mutated AML do really poorly with everything, including aza-ven, median survival of 5 months, as opposed to the TP53 non-mutated, where aza-ven is giving us excellent median survival of 19 months. So we still need to do new things for TP53 AML. That's where the drugs like magrolimab, APR, maybe some of the bispecifics will come in. Moving to immune therapy, there's a couple of abstracts I would say are quite interesting. Flotetuzumab, which is a bispecific CD3, CD123, is going to have updated data presented by Dr. Abraham Aldo's oral presentation, looking in primary refractory and early relapse AML, where they're showing quite encouraging CR/CRi rate, close to 40-42%, which in this population is very good, but because historical CR/CRi rates have been about 15 to 20%. The median survival is about 5 to 6 months. That's a little better than historical, but I think we would like to see a better improvement in the median survival and duration of response. But among all the bispecifics in trial, flotetuzumab does seem to be the one moving forward. And there's also some biomarker correlative analysis that will be presented by Dr. Rutella, one oral presentation, one poster, showing biomarkers of response to flotetuzumab, looking very detailed at the immune microenvironment, especially in the setting of TP53 and other mutations. So I think that's a good one to look at. Other immune therapy, there is a CD123 antibody drug conjugate, IMGN632. This is being looked at both in AML and in BPDCN. At this year's ASH, the focus will be on BPDCN. This will be presented by Dr. Pemaraju, showing that in relapsed refractory BPDCN patients, IMGN was giving an overall response rate of 30%, which is good, but more importantly, we were getting responses in a lot of patients who had failed SL401. In the pre-SL401 exposed patients, the CR/CRi rate was being maintained around 30%, which is very important because this is becoming a major area of unmet need. Also, this antibody seems to be very safe. We don't see any CRS, no capillary leak syndrome, minimum to no VOD, and can be administered outpatient every 21 days. So maybe a good option to use instead of SL401 for PPDC, and I would look out for that data emerging. FLT3, there's going to be a lot of new data. Venetoclax, gilteritinib in relapsed refractory FLT3. I'll be presenting that data. Looks quite encouraging. Very high CRC rates. Very encouraging early median survival duration of response. We're also going to be looking at the first time at triplet data, which is something people are very excited about for the next few years, of decitabine with venetoclax with quizartinib. Dr. Yilmaz will be presenting this, showing very, very high response rates, both in relapse and frontline. Small number of patients, but giving us a taste of how these triplets, when used optimally, and that is something he will focus on, that we are shortening the venetoclax to 14 days, using growth factors, sometimes interrupting FLT3, but I think it's important that these triplets can be very, very effective, better than anything we have ever seen, but also are myelosuppressive and need to be done safely, and these trials are quite critical. We're also going to have some data looking at the mutational escape pathways after type 1 and type 2 FLT3 inhibitors. Dr. Ala Taibi will be presenting this, and it's quite interesting to see that people failing type 1 FLT3 inhibitors like gilteritinib and midostaurin had a high enrichment of RAS, MAP kinase, and other FLT3 non-canonical mutations, which was very different from those failing type 2 FLT3 inhibitors like quizartinib, sorafenib, where most of the emergent mutations in escape was driven by FLT3 D835 or IDH. So I think, again, we try to put these FLT3 inhibitors in one group, but really they're very different. And just like CML, we probably will be selecting these drugs based on the pre-treatment and evolving mutational landscape, suggesting that there will be a very important role for all of these drugs, maybe sequentially, and they are not competitors, but probably complementary agents to be used in the future. So these are some of the high-level thoughts. There's also going to be an update in frontline with azacitidine in TP53 AML, as well as wild-type AML, showing very encouraging activity that we think will be taken forward in the future. There is going to be additional data looking at sorafenib in the frontline setting from the Australian group. This is a study that's been going on for a while, showing that sorafenib added to induction chemo does seem to improve response rates and could be an important path forward. So these are just a few of the abstracts that I can think of. There are probably many, many others. One important one I will mention is a menin inhibitor. So this is something that is very new, probably the first time this data is presented at ASH, looking at Cura, MLL rearrangement targeting drug called menin inhibitor, presented by Dr. Wang. We think this is the next frontier of targeted therapy. We have the FLT3, we have the IDH, we have the IDH2, TP53. It looks like we may have one or two drugs, magrolimab APR, and now MLL rearrangement, another very high risk, difficult to treat population. For the first time, we're seeing up to 40-50% single agent complete remissions, including complete cytogenetic and MRD clearance with these menin inhibitors. So we believe that this is a very important targeted approach. And then, of course, as we combine it with azaven and chemo in the future, this may really improve the outcome for these MLL rearranged patients who do really poorly both in AML and in ALL. So I think I'll stop there. Of course, there are many others. And again, I don't mean to leave out anything. I'm saying what I can remember at this time. But looking forward to a very, very exciting ASH meeting. Thank you.